The ALPINE trial was a randomized comparison between Ibrutinib and Zanubrutinib in a largely all-comer population of relapsed refractory CLL patients who in the end had a median of 1 prior regimen. And the primary endpoint was overall response rate, which was improved by Zanubrutinib compared to Ibrutinib. But I think most people were interested in the progression-free survival data, which have shown a consistent benefit of Zanubrutinib compared to Ibrutinib at the first 2-year analysis and then at the longer, almost 3-year analysis. We continue to see a significant 10% benefit of Zanubrutinib compared to Ibrutinib. And interestingly, amongst the high-risk patients with deletion 17p, the difference in PFS favoring Zanubrutinib is even greater than it is in the lower risk patients, which I think does really underscore that this is probably a real benefit in terms of disease control and not just related to people stopping for adverse events, for example. We also did some sensitivity analyses to evaluate that and found that there was still a significant progression-free survival benefit for Zanubrutinib when looking only at progression events that occurred on active treatment. And in terms of toxicity, the risk of atrial fibrillation was significantly lower with Zanubrutinib than Ibrutinib, as was the risk of cardiac death and the risk of drug discontinuation for cardiac events. So all in all, ALPINE showed a significant benefit for Zanubrutinib. I think the primary barrier getting Zanubrutinib into standard of care may just be physician comfort levels. At least in the United States community, for example, people got used to Ibrutinib. Now they've gotten fairly used to acalabrutinib. But it does seem like people are pretty motivated to move to Zanubrutinib based on these data, so we'll probably start to see increasing uptake.